For the last session of the day, we have three speakers and myself included on the issue about HCDRM again. We have our first speaker, Dr. Saurabh. He is going to talk to us about Safe Hospital in India. Just a brief introduction for Dr. Saurabh. He is the National Professional Officer for Emergency Risk and Crisis Management and the World Health Emergency Program with the WHO Country Office of India. He's also one of us, emergency physician, trained in emergency and disaster medicine and specializing in biological disasters, public health emergency management, hospital safety, CBRNE, and weapons of mass destruction emergency management. So he's contributed to training, frameworks, curriculum, and he's currently the focal point in COVID-19 pandemic response for all UN agencies in India. So without further ado, I'm going to hand over to Dr. Saurabh.
Yeah. Good morning to all, and thank you, Kevin and team, for inviting me for this particular talk. Today's presentation is going to be very in brief presentation with regards to how we have learned from the experiences of working on a very specialized area of hospital safety. So before we start, I would like to just put a disclaimer that all the experience today that I am sharing are based on my personal experiences and my involvement on policy making and rolling out the programs across the country, and are not being endorsed by any organization as views. So this particular part of hospital safety has been a challenge across the world. So looking at the situations, even now, almost all countries in the world have probably are not able to perform so well in the terms of extending their surge capacities, uh, providing a safe environment to the patients coming to their places. So we always say that hospitals at this point of time across the world, we see that the offices are closed, everything is closed, but the only things that remains functional 24/7 are our emergency rooms and all our hospital. So we often say that ill or not ill, but everyone will come to you. So whether it's a trauma, mental health issue, or even a minor scratch, people will come to your emergency room during any sort of emergency. The very simple reason is because there is someone over there who is there to listen to them and will guide them for a solution, not just during the daytime, but at any part of the day, any time, and even during the late hours in the night. So, but we also see that during emergencies, around 50 to 60% of the patients coming to the emergency rooms are requiring just a very minor care, or even just a counseling sort of thing. This often leads to overcrowding in the emergency rooms, and then the emergency rooms collapse because they are not able to provide the service which they are really meant for during the emergencies. So across the world, we see that doctors all around the world, nurses, paramedics, and all the healthcare staff are doing their best at this moment. I'm also reflecting upon the current situation that we have, not just in India, but even in many other countries. We are extended, stretched, and working beyond our capacities, but still, it's not very easy to satisfy each and every one and provide the best of care and the best of services to all the people who are coming to us for the services. Adding to that is, it becomes even more grave when the people who are coming to us for the particular set of treatment are not able to get so, but are affected by the internal or external disasters. That even becomes worse. So, and the another aspect of is when a disaster impact a healthcare facility. We always see that there is a huge amount of disruption in the manpower, processes, trainings, and infrastructure. So when all this thing comes together, it creates a big havoc, and healthcare facilities during a time of disasters are extremely badly affected. Let me take you through many case studies and on what we have learned so far, what is good, what is bad, what has worked for us, and what has not worked for us so well. So during disasters, the hospitals becomes the primary institution to get affected because of heavy number of flow of patients affected by the incidences. So most of the hospitals have started responding to emergencies in the initial days in an ad hoc manner. Very recently, after the WHO Safe Hospital initiatives and individual countries, they took the cognizance of the area of problem, and then they started developing a science around it. So much so that the earlier part of earlier during these emergencies, people were not held accountable for what is happening in the hospital. And if you see the current trends across the country, the medical director, the superintendent, the CEO of the hospitals are immediately fired within 2 or 3 days, and strict actions are taken by the government across the country. So India has learned a great deal of uh, lessons from the past disasters, and really one of the such incidences of AMRI hospital, which just recently featured in one of the best hospitals in India, and even featured at in the year 2011 when a major fire break out there. So of course they are built like a 5 and 7 star hotel facilities. They provide best of medical care, but often they neglect and compromise on the safety issue. The reason is they are not properly planned. They in some places, whether in rural or urban areas, they were constructed in some ad hoc manner. They take certain leverages to expand the patient care areas and service delivery areas, and at the same time in the initial part where there were no proper rules for evacuation and fire safety, so a lot of the hospitals which were already there in the old buildings are coming up in a mixed structure buildings or in uh, hospitals which have been 50 years or old. These are a few challenges that we face across the country. It's also very difficult that uh, we every time would not have someone or a superman healthcare professional who is going to stand up and save life of thousands of people and help in evacuating them before he even gets out. At the same time, we don't even want a patient who has come to us for a help to be rescued by non-professional people who do not know a proper technical evacuation, and then we in the next picture we can see the spine and the immobilization severely compromised. But of course it's a life-saving procedure. They are doing the best, and but the thing is training, proper planning and infrastructure is to blame. So after the AMRI hospital fire, and after that, there have been a series of major fires that have happened across India in the hospitals. I'm very sad and unfortunately to say that in not just in India but across the world, there have been more than 96 major fire incidences in the hospitals, and these hospitals were COVID specific hospitals. So, almost more than 2,000 people who were admitted there in isolation or in ICUs for treatment because of COVID 19 have lost their life, not because of the proper treatment or ventilator failure or oxygen supply, but have lost their life because of fire incidences, ventilator blast, improper evacuation, stampede, and various other reasons. So, it's not just in India, Bangladesh, Bulgaria, USA, Russia, many other European countries have also faced the same challenges, and the hospital safety issue pops up every single time. So, looking at the vulnerability of India, we know that we are pretty vulnerable to almost all sort of disasters, be it flooding, be it cyclones, tropical cyclones, tsunamis, earthquakes, landslides, avalanche, flooding, heat waves. So most of the part of the country are vulnerable to different sort of disasters. So similarly, being such a wide and vivid country, a similar sort of planning template or a generic disaster management plan would not suffice for the entire country as well. So we were very very specific that the definitely the hospitals located in the northern part of the country, in the Himalayan belt, or maybe in the plains in the central part, need not prepare for the specific risk of tsunamis and cyclone. But so we wanted to make sure which hospital tends to do much often, that there should be no copy paste of the hospital disaster management plan available on the internet. And this is a very common practice, not just in India, and I've seen this across the world. As a healthcare professional and as a disaster management professional, what we see and what we experience is people who are not working in the emergencies often tend to use the words emergency, crisis, and disaster interchangeably, and they really do not understand the concept and the meaning behind this, and this leads to different level of activation, creation of unnecessary panic, and the concepts not being clear to them leads to a lot of chaos during the times of emergencies as well. At the same time, not just here but across the world, people are very much bound with the belief that any disaster that's happening across the world or a country cannot happen to us. We are in a safer place. Disasters are so deadly that all the victims will die anyway, and there is nothing much we can do. This is a tendency of a general population which we see in normal times. So, but when we really focus on this particular question, the question we really need to ask is that can we prevent? Are we prepared? Can we mitigate these incidences? And are our response mechanisms adequate? One of the first major case study that I'm going to share here is the Gujarat earthquake, one of a very major earthquake of 6.9 Richter scale, which happened in the state of Gujarat, and was a turning point for the disaster mechanism in the country. And then the institutional framework within India came up. So there were so many healthcare facilities that were damaged. More than 300 major hospital facilities were damaged, and one of the major healthcare facility was the prime community healthcare center, which was located in the, and it was a big hospital, ongoing operations, and it was an Independence Day of India. So the it was a celebration going on. The surgeries were on, and around 325 people really died in a building that really collapsed. So, and it was a massive, massive earthquake. But not everything is bad about the disasters. So, we tend to build up better in a way that now the hospital that stands in its place has been built, and this place is always going to remain in an earthquake prone zone. And the hospital, which has was re-erected just in 4 years, was built upon base isolation technique and literally can shake up to a Richter scale of 8.5 and still remain operational and functional. This particular hospital, even at this point of time, is catering to more than 700 patients, and being in a rural area, it serves a very good purpose. So let me come back to the AMRI incident. Every hospital fire incidences, we have learned certain things. The most common causes are short circuits and delay in response because people are not very much aware on what to do. Poor maintenance of and replacement of the electrical stuffs, as well as overloading and multiple plugging of which we can all see and relate to our own hospitals as well. So the conclusion of this AMRI hospital fire that forced India to make a policy on hospital fire was hospitals were not following the fire safety norms, flammable and radioactive material storage was improper, and staff were not handled to staff were not trained to handle such a situation. The very core reason was the community who was not concerned with the hospital and was living around came to the rescue of the people who were stranded inside the fire, and the staff, and it was a very shameful act where the staff who was working there actually fled away. And then the government realized and analyzed that those people who are working day in day out in that particular facilities, even if they cannot do evacuation, they were the best people to guide the entire response to how to reach in a particular ICU. A nurse working in that ICU could have guided the evacuation forces, the fire safety team, and the community how to go there and take the people out from there. But instead, they fled away. So this was one of the very wrong examples set, and then a huge amount of uh, policy were made around this particular issue. Making policy was not enough. Again, we saw that after multiple years, these same fire incidences uh, were repeated. The only difference that happened in the 5 year period of time was it took around 3 to 4 years to punish the culprit in the particular incident in 2011, while one of the similar incident with a very less casualty happened in 2016, and the punishment to the culprit was in less than 7 days. So this is how making the policies, implementing them, has really helped the government. Also, not every time the fire is the cause. Locking of emergency exits, creating stampede. Then people not applying common sense like breaking of windows, and that applying a very basic norm that fire doesn't kill people, smoke does, smoke inhalational injury does. So all these things when were slowly being incorporated into the training culture, and then we were able to avoid multiple incidences. Also, it was not just when we talked about a comprehensive issue of hospital safety, it was not just hospital fire, but also bomb blast with the hospitals and the emergency department being targeted in various parts of the country, landslides affecting and mudslides affecting many major infrastructures in the Himalayan belt, and also flooding and overflooding the hospital infrastructure. We can see the damage being caused by a simple mud to a CT scan and a very expensive machine like this, which is being provided to a district or a community level hospital. This is virtually irreplaceable. And the cost of restoring such equipments would be actually more than the cost of reconstruction. So it doesn't serve the purpose of, and this shows a clear example of poor planning. Apart from that, several more scenarios popped up every single time, and then the government decided to take a very stringent action on this particular issue. Even during COVID-19, as I mentioned, there have been so many multiple fires, and so many people have lost their life, not to COVID, but to this fire incidences across the world. So, and every time there was a need that there is a National Disaster Management Authority guidelines on hospital safety, and which analyzes and shares the gap on how hospitals need to prepare for this particular issue. It clearly outlines 2 to 3 different things. So the challenges are that nothing big works unless it is needed, backed by the government policies and facilitated by partners for execution. So all of us have a good amount of experiences in workshop, training, seminars, conferences, initiatives, and are hardly 10% of the real work done. Major 90% is at ground level coordination, execution, planning, and implementation. And often we ignore community while we do the capacity building, and these are the people who come to our rescue. So community capacity building is must for every major program, even in an area such as a hospital safety. So India released a guideline on 2016 February on a hospital safety, and it is probably one of the most used and referred guidelines. And around 56 countries have now replicated their hospital disaster management national policies, taking reference from this particular guideline. So we also had guidelines on management of biological disasters, scaling up of fire services, medical preparedness, and mass casualty management. And since the National Disaster Management Authority being the topmost authority chaired by the Honorable Prime Ministers, all these guidelines had a biting tooth and a severe implementation framework. So it very what was the primary roles of this guidelines was to allot the nodal ministry or agency for this particular emergencies, and then also chalk out the roles of all stakeholders. How does they perform, and what are their roles and responsibilities? So again, risk communication turns out to be a very important, and this is what we often lack while we do and carry out our all initiatives. Also, the government took a very cognizant stand to highlight this particular agenda in front of all government whenever an international meeting like Asian Ministerial Conference or global initiatives on disaster risk reduction happens in the country or where India is representing its disaster risk reduction practices. So risk communication and community awareness became a very important part. The hospital safety guidelines were clearly mentioning three parts. What is the role of a person within the department? What is the role of a department within the hospital? And what is the role of a hospital within the community? So these three particular aspects were clearly outlined and highlighted in the hospital, just to make sure that the hospital safety guidelines are being implemented very properly at all the levels. The government of India also started a quarterly monitoring and reporting format for all the state governments. So every state and has to fill up this template and submit to the national authorities, Ministry of Health as well as NDMA. Uh, how many hospitals have prepared their hospital disaster management plan? The number of hospitals that have conducted safety audit, both structural and non-structurals, retrofitting done, corrective measures taken, mock drills conducted, obtain NOC from the fire department, changes in architecture, structure, and design, training for different cadres of disaster healthcare, like disaster nursing, public health, administration, design, and construction, as well as inculcating the disaster medicine curriculum of patient and life safety in all the medical and nursing colleges. Having a district and a state level coordination for the disaster management planning and dissemination of IEC material training programs, and also geotagging of the healthcare centers. So far, it also contains not just only big hospitals, but also government hospitals, private hospital, medical colleges, CHCs, PHCs, primary, secondary, tertiary healthcare centers, alternative medicine centers, TB and infectious disease hospitals, trauma centers, railway public health facilities, and all other referral centers. So it was not just limited to one sort of healthcare infrastructure, but you will be surprised to know it, like such a wide country like India has more than 11 million healthcare facilities. So uh, to have a comprehensive planning for all, it definitely takes time, but after this implementation of this particular format, around 30 to 50% of the healthcare facilities and all major hospitals which have been geotagged, and in a way that or major hospitals have been having a disaster management plan, are clearly geotagged on the national reference maps. So, what were the key lessons wrong? Evacuation has always been a biggest challenge. Backup and emergency power supply has remained a major challenge in many places where they face recurrent flooding, and communication systems often tends to fail. The reason is because the communication failure of the tower networks and other thing. So, in the hospital disaster management plan, they often work out many new modalities of communication to the staff and getting the surge staff. So what have worked for the healthcare facilities, that emergency plan in place, networking with other healthcare facilities, and having a centralized incident command system has always worked for the healthcare facilities. So again, while we deal with the issues of medical professionals, it's also that medical professionals often think that they are the first line of response. So it is always taught to them that they also need to work with the urban search and rescue team, hazmat specialists, CBRN teams, and other government agencies. They are not just only response; they are a part of a complex response. So a way forward is, even for we have seen this, and we are now sharing these experiences with the SAARC countries as well. So have a stock of your people, personal equipments and supplies, know what's available, where is it, and how to get it. And concept of disaster management like incident command system, incident response systems definitely work well. And institutions, be it offices, healthcare facilities, or hospitals, with a disaster management planning works well. So we encouraged our hospitals to start small and take cater to a few emergencies. Call them to do three mock drills a year. Call a third party observer when they do mock drill. Call the district disaster management agencies, hospitals nearby, and conduct three times a year mock drills, two planned and one unplanned. And do not wait for disasters to happen. So this has probably worked so well in the country at the moment. And basic skills were taught, like triage, but the major takeaways are a lot more needs to be done in this particular area. Risk informed planning needs to be done very properly, and should be the success from this should be widely circulated and shared. Policies must be practical and solutions must be strategic, and each and every challenge needs to be dealt with an innovative solution in a customized manner. So this particular experiences of India has helped us as a country to somehow mitigate the major issues of fire, and in years to come, and also learning from the COVID experiences, this thing and this particular agenda is also going to go higher and higher. So as Socrates said that I cannot teach anybody anything, I can only make them think. So this is what an idea which even we thought would make hospitals think properly to plan for their emergencies. So thank you very much, and I'm ready to take some questions.
Well, thank you, Saurabh, for the very informative talk. Hello. Yeah.
Yes, yes.
So yes, great. So yeah, very tragic stories we've heard there. Um, the fires we've seen, and the damage, and maybe what's more tragic is that some of these may be very preventable, as you've said. Um, and congratulating on your guideline, which has seemed to have moved things forward, covering a range of issues, including structural, non-structural, evacuation, which is always an enormous task to evacuate a hospital. It's often a nightmare. And then also the issue about this business continuity and the sheer volume of health facilities, 11 million.
Hmm.
So maybe just we wait, since we're waiting for questions from the chat box, just maybe for us to understand a little bit. So just wondering whether any hospital fires, even without casualty, are they sort of managed or overseen by the NDMA?
So we have a system of reporting called FIR, First Incident Report. So any incident that happen across the country needs to have a first incident report, which has to be submitted within a period of 24 hours to the local authorities, and then the local authorities in turn submit it to the NDMA. And if there is a major fire and if there is a request, it's always even submitted to the Prime Minister's level. So it's a very clear reporting mechanism, and every what went well, how big was the response, what was the primary cause, what were the fatalities, and uh, could have been prevented. What are the next steps that needs to be taken? So even a reporting mechanism has been clearly in place, and probably that's the thing that is. So after the report, most of the ministers or the higher level authorities tend to give a response, and once they do it, it again gears up the preparedness cycle. So
Right. Yeah. Because I think not all jurisdictions will have the National Disaster Management Association. And even perhaps when we have such association, how do we clearly define disasters in the local jurisdiction and among the health sector? And hospital is definitely core of the health sector. So in different jurisdictions, there may be different stakeholders and responders.
yeah,
And so I think it's good to learn from the Indian experience, but at the same time, I think some of these will make a lot of difference in terms of who's responsible and who's driving this. Just a follow-up question from this side is, how do you see the resources coming in? Because my understanding of the Indian health system is that there are public and there are private hospitals, and the funding mechanism would be quite different. But in terms of following the Safe Hospital initiative, or when work has to be done, does is there funding for all hospitals, or how is it going to work?
yeah. So every hospital, especially like even a public hospital or a private hospital, has to prepare their disaster management plan. So in that they have to put up their own resources. But when there is an district level mock exercises, or even there is a preparedness activity, then the state or the district level governments also give them a good amount of funding to carry out such activities. If they are also a part of a national or a local level drills, then there are certain incentives which are being provided to them. There is also a dedicated disaster mitigation fund, 10% of which is also being used for the capacity building of the healthcare staff. And even in the national level training programs, the state level training programs on hospital safety and preparedness, the government invites the participants not just from public hospitals but also from the private sector hospitals. So looking at so far, almost 15 to 16 million people have been trained in this particular area. Uh, the There is also a big challenge that we saw while we train them as a mixed group of people. So there are hospital administrators, nursing, security, and everyone sitting together while we discuss an issue of hospital safety. So across the world, the trainings happen in this way, which we thought is not a proper way to go ahead. So recently, what we have done is we have divided all the cadres of hospital safety training into four different cadres. So it's a primary, secondary, and a tertiary level trainings for hospital safety. It focuses on very specific areas, what needs to be done by a security staff or nurses, junior consultant, intern, or then in the second level we have doctors, senior residents, the nursing in charges, the nursing supervisors, the pharmacy, physiotherapy, and other staff, the maintenance and other things. In the third one, the hospital administrators, the head of the department, the CEOs, the MDs, and how do they coordinate or kick up their incident response command system, and how do they coordinate with the district authorities. So very specific modules have been designed. And the fourth one is those who give permissions to the hospitals. So the module is excessively focusing on assessors, on what fire safety permission needs to be given, what are the construction and structural, non-structural permissions, and checklists to be followed in hospitals. All these things are being done in the SSS module. So probably in 3 months from now, these modules will also be released, and this will serve and go a long way in creating the focused way of capacity building and force multiplier in terms of developing disaster medicine capacities in the country.
Thank you, Saurabh, for your detailed explanation. So one question from the floor. I guess this is the last question before we move on. Any inspection requirement by your fire authorities in your country? Is it a requirement that hospitals comply with these fire regulations?
Yeah. So every year, hospital has to obtain a no objection certificate from the fire department in order to renew their licenses. So this is a prerequisite that hospital, whether government or public, private, has to submit to the government in order to for the extension of the licenses. So most of the hospitals does that, and a few hospitals that are running in silos are not very prominent. They usually tend to escape this mechanism, and they are the ones which mainly get affected. So all major hospitals, of course, without an NOC or fire, cannot run. So this mechanism also now is being very strictly enforced across the country, and it's a minimum requirement to operate a hospital.
Thank you, Saurabh, and hopefully things will move forward in a more prepared way, thanks to the work that you're doing. If it's okay, then we can move on.